There is another interleukin 17A and F inhibitor that is in development, known as sonelokimab. This is a interesting molecule in that it's a nanobody, so a very small molecular weight. And one of the potential promises of nanobody constructs is that they may have better tissue penetration. This has been shown, for example, in some cancer indications where nanobodies have been employed. So this new agent will have further data from phase 2 being presented at the upcoming ACR meeting. And we are looking forward to its continued exploration in phase 3 in psoriatic arthritis, and potentially in the future, other indications like axial spondyloarthritis. There is another agent known as izokibep, which is an IL-17A inhibitor that is also a small molecular weight construct. And we've had positive data in psoriatic arthritis presented on that particular molecule. There are other interesting small molecules coming forward, including one from Janssen, which is an oral IL-23 inhibitor, and others. So the field continues to expand in terms of potentially available medications for us to use. Other research that is important in the field of psoriatic arthritis is coming out. We've now completed a study known as AXIS. This is a collaborative study between the GRAPPA group and the ASAS group, in which we're trying to come up with a definition for and potentially classification criteria for what we're calling axial psoriatic arthritis. We know that in psoriatic arthritis, one of the clinical domains that can be present is axial inflammation or spine inflammation. This is immunologic process in the spine and sacroiliac joints. This has been identified in up to 40% of patients with psoriatic arthritis. But we've had some difficulty in knowing how to define this. Do we do it based on clinical features? Do we base it on MRI findings or X-ray findings? What about the genotype of these patients? We know that in axial spondyloarthritis, up to 85% of patients may be HLA-B27 positive, but in studies with axial PSA, only up to about 30% are HLA-B27 positive. There are also some subtle and important differences in clinical presentation between axial PSA and axial SPA. For example, a patient may not have sacroiliac joint involvement, but may have cervical spine involvement. Or the patient may present much later in their disease course with psoriatic arthritis, for example, in their 40s or 50s, whereas traditionally AxSpA patients present at a younger age. We've also seen some subtle differences, or not so subtle, in terms of treatment response. So, for example, in axial spondyloarthritis, interleukin-23 inhibitors don't seem to work based on trials with risankizumab and ustekinumab. But in a post-hoc analysis of data from phase 3 trials using guselkumab in psoriatic arthritis, in patients whom the investigators thought had axial PSA, there appeared to be a positive response using guselkumab. So Janssen has launched a large trial known as the STAR study to look at whether or not guselkumab can work in patients with axial PSA as defined by MRI. So having a classification criteria is going to be important. And some of the top-line data has already been presented at some of our clinical meetings, such as the recent GRAPPA meeting. And what we're seeing is that a significant percentage of psoriatic arthritis patients, at least 27%, based on both imaging as well as investigator assessment, have what appear to be characteristic inflammatory features based on MRI of the spine. And so we're looking forward to more of that data coming out and being presented at upcoming meetings.